Thank you very much, Doc, for the introductions. I featured here this morning, and so it's delighting to be back on this podium to discuss with you a few considerations for addressing the socio and structural determinants, and with a bias on how do we then empower women for better quality life. If you look at that broadly, before I get into my conversation, the sessions that we've had this morning have pointed out to the male engagement. The sessions that we've just had here, including issues around, do we discuss sex and in relationships, and what is the impact of that? And so many of these conversations that have more questions than answers. So I have no conflict to declare. Rather, I want to bring you to Othoro Health Center in a county in this country where I have been implementing one of the interventions in this country called G-Power. And this is a peer-centric model that targets and works with adults and girls and young women who are pregnant and breastfeeding, both HIV negative and positive. So at this facility presents an 18-year-old girl who suspects that she has malaria. But because the facility has a peer mentor who is herself a young lady who's been trained to manage the cases of adults and girls and young women, she therefore uses her skills, the motivational interviewing skills, and other set of tools to assess the needs of the adolescent girl. What does she find out? That the lady was actually married at the age of 17, and she is pregnant and has tested HIV positive during this visit. That's because the project does what you call the triple screening. It screens for HIV, pregnancy, and gender-based violence. So on the material day, she is unprepared to be initiated on ART and goes back promising that she will come back to the facility. And because the peer-centric approach allows for follow-up, the peer mentor follows her up, and the next time she comes with her husband. In the process, it is discovered that the husband has actually been on treatment, but did not disclose his status to the lady at any point. However, during this visit, she is initiated. So I've got a few questions. Do we see such cases? Noting that majority of the clients that we see in our MNCH are actually adolescent girls and young women. Do we see cases of such ladies presenting to our facilities? And in terms of intervention, at what point could we have intervened? Is it at the policy level? The conversations that Maureen was bringing up, that, the disclosure of HIV status, should the man have been required by policy to have disclosed his status? Or could it have been that the intervention could have targeted the adolescent girl like they do with other programs like the DREAMS? Could it have been that the interventions like U equals to U would have been working and these men would have been virally suppressed, and possibly that there would be no need for possibly having that conversation, or having that conversation but from a point of, I know I cannot transmit? Could it have been that we would have offered PrEP to these adults and girls? And what would have been the basis for doing so? Would it have been a requirement like some churches used to do, that then they say, for premarital, services, we need to offer you counseling and testing? Or was it just some of those lacuna in the legal processes? But again, as you've heard, some of those legal issues are criminating persons living with HIV, and therefore, where would it have been? So there are more questions than answers. And I know you're still thinking about this. And so we get to the next point of asking ourselves, what is this when we talk about male engagement? Is it getting your partner to accompany you to the health facility? And once the men come to the facility because they have been asked to accompany, what are they supposed to do at the facility? Is it a beautiful thing? Because the indicator usually is that at least you accompany to the facility at least for one ANC visit. So what do we achieve by that visit? 2, how do we measure change? Is that change implicitly personal or structural or social? Do we focus on men as the partners of women in a relationship that need to be seen as their partners at every level? Do we focus on the men as champions who can bring about change at the household level as well as the policy level? But also, do we focus on men as either husbands or fathers, or as individuals? Can we broaden the engagement beyond accompanying? Is there a place for men at the health facility when they are seeking for these services? Would those be in the areas of policy advocacy, alliance building, community mobilization? Or how do we work with men for individual and structural changes? So at a programming level, what are we trying to address? And I think it is important for us to acknowledge that there is insufficient intention and attention to engage men in HIV response. And that largely comes in the area of looking at those programs that target the men themselves as individuals. Because when you're asked to accompany your partner, what is the service that's there for you other than accompanying? And then, what would we look at in terms of being the successful outcome of that engagement? Again, we lack or we have inadequate disclosure of HIV status among HIV positive men to their sexual partners. We know, for example, that when women test, especially those who are pregnant and breastfeeding, we tell them, bring your sexual partner. Is there the same intensity when it comes to men? The metrics, what we measure, the data on male engagement is often not collected, and if it is collected, then it is typically based on the number of male partners attending at least that one visit. And the next one is that some of the men who have sex with other men also do have sex with women. So I think from Dr. Ruth's presentation yesterday, it did indicate about 60%. So when we are talking about, male engagement, what's the space for services for these other men? And we know the risk that is attendant to such relationships. And of course, there's the whole question around socio-cultural, expectations that typically feminize the participation in ANC, for example, but takes back the decision-making to the men. So as we look at that paradox, it is important to just shed a light on a few things that we saw in one of our projects, the JUA project. We learned that majority of the young people, 2024, are actually the ones who are making the girls that we had in the project pregnant, followed by those of 25 and 30, and then 30 and 34. What are the services that we are having specifically targeting this audience? If we talk about dreams, for example, and other programs, we talk about characterization of sexual partners. But when we characterize them, who are they? Our experience with the characterization is that they are as diverse as they come. So with that diversity, then what do you do with a diverse set of men in terms of offering the services? 54% of them are married, either to other women or to the same adolescent. What is that package of service? Look at GBV. Overall, 27% of the adolescent girls and young women that we served in the last 1 year had a case of gender-based violence. And therefore, the men come into the question. But what is the GBV services targeting the men? Because our GBV services are targeting the woman who is already at the facility. What is it that we are doing to reduce that among the men? So in terms of male engagement, I think the best questions we need to ask ourselves is all those things that we have talked about, but then our best of intentions sometimes could actually be the ones leading to unintended effects. Sometimes we insist, either by protocol or just overzealous providers, bring your sexual partner. We know of cases like in Uganda, studies that showed that what happens, the women just pick any man and bring them to the facility because you want a man. Possibility of GBV, and many other things. So in terms of programming, why then do we need to target men? Because there's still discrimination and social stigma and the fear of losing our masculine identity. And so how do we address those in terms of reframing the whole conversation around male engagement? Most HIV programs, as we said, still fail to specifically target boys and men. Over the years, boys and men have not realized significant benefits or targeted investments. And so we need to think around how we then engage these men. And there's a host of partner services. Some of them are bundled, some of them are psychosocial services, some of them are services where we invite men through the women again, and some of them are community, demand creation activities. All these activities, when we look at them in terms of partner services, I think the key word is let's reimagine the male engagement discussion without unduly putting the burden back to the women. So in terms of call for action, we need to have an adaptation of male engagement to local socio-cultural context beyond a national program, for example. In Kenya, when you talk about men, for example, think about the men in certain regions of this country. Are they the same? Men are not the same. And so think about all that. Improve community-level education for men and reframing cultural norms to include men across the cascade. Be more intentional in the identification of opportunities to link men to HIV priority programs. Provide mechanisms for strengthening capacity of actors, because some of the providers do not know how to engage the men. Enhance policy dialogue, especially those policy areas that do not address the issues, but rather keeps criminalizing persons living with HIV. Provide guidance on development and coordination of male engagement. And lastly, provide for recommended package on male engagement for the HIV response. Because for us to address the social and structural determinants, we need to think above site level. Then we can go to the site level and offer the services that are responsive to the needs of the men, but also that address the vulnerabilities of the women. And that way, then we have a collective response to the HIV and women. Thank you very much.